Good afternoon, everyone. Welcome. My name is Henry Perry. I'm on the faculty in the Health Systems Program of the Department of International Health. It's a great pleasure to have you all here today for this very special occasion. We're going to be on a kind of a limited time schedule because we have to be out of here by 1:20 since there's another class, and I'm going to be the moderator for this session. And I'm going to try to move things along because we have so many outstanding speakers who have a lot to say. But let me welcome you and simply tell you that we're going to have an exciting program today that will begin with a keynote address for about 10 minutes or so from Minister Kesete Birhan Admasu, who, for those of you who don't know, is considered to be a rock star in global health. He's young and exciting, charismatic, but also incredibly competent, and has done a tremendous job leading the development of primary healthcare services in Ethiopia. And he's going to share with you today his vision for our International Institute for Primary Healthcare. After he speaks, we're going to show a brief video from Dean Clegg, who sends his regrets, but as I'm sure we all know, Dean Clegg has been involved in important activities in New York City and is engaged in more of those today, so he could not be here. After that, Professor Mengesha Admasu, who is the new director of the Institute, will say a few words. I'll say a few words. And then we're going to have a little bit of time for questions and comments from the floor, and then some closing comments from David Peters, the chair of our Department of International Health, Dr. Sharfstein, our associate dean, and also from Oying, Rimon, the director of the Bill and Melinda Gates Institute. So without further ado, let me invite Minister Cassetti to come forward and let him share with you his vision for what has taken now about 3 years to get underway, but we're finally underway. So Mengesha, thank you so much for coming.
Thank you, Henry, for the kind introduction. Good afternoon. It's my pleasure to be here at JHU. It's my second time to speak here. The first time I spoke was 3 years ago, and 4 years ago, I should say. I talked about the health extension program in Ethiopia and how it has helped the country to improve its health outcomes and do better in terms of improving access and basic health services for the majority of the people. And today, after a long journey, we are here to celebrate the launch of the International Institute of Primary Health Care. When we set up this Primary Health Care Institute, the idea came as a result of a discussion I had with my friend Oying when we hosted the 2012 Family Planning Conference in Addis. We were discussing potential areas where we can engage Johns Hopkins University in Ethiopia. We have so many project-specific collaborations over the years, which has been very successful. But I had this vision of having a world-class primary health care institute grounded on the reality in Ethiopia. Because of the health extension program, the primary health care system in Ethiopia has been popular, and more than 50% of sub-Saharan African countries have come and visited the program. What usually happens is ministers write an email or a letter to the Ministry of Health. We arrange people, we assign focal points within the ministry, they receive the delegations, they show them around. Most of the time the delegations get excited because we show them the best places, obviously, and they want to go back and start a similar program. But most of the time, communication breaks down. And again, a new minister in the same country comes into the position, learns about the Ethiopian Health Extension Program, requests for a field visit. We do the same thing all over again. So I thought it would really be important to have this institute that can provide a very good platform to share our experiences, starting from the philosophy of the health extension program, how the system is designed, what the challenge we have faced over the years, the mistakes we have made, and the fixes we have put in place, and so on, so that when countries decide to start a similar program like the health extension program in Ethiopia, they don't have to do the same mistakes we have made over the years. Because if countries decide to start a health extension program similar to Ethiopia, it will not be cheap because it requires the community health workers to be on government payroll. And as you probably know, the wage bill in many sub-Saharan African countries is already huge. So adding substantial number of community health workers into the public service wage bill is not an easy decision. So when you design a program like the health extension program that can potentially have a huge impact in terms of improving access to information, improving access to basic health services, and most of all, empowering communities to take over their own health is a good decision. But it needs to be supported with an evidence grounded based on the reality in sub-Saharan Africa. So that's the genesis of this International Institute of Primary Health Care. But we have also a selfish reason for setting up this institute, because fortunately in Ethiopia the civil service salary scale is low, and most of our primary health care directors, health extension program managers, and so on leave their posts often. So the attrition rate is very high. So when you hire new people into the position, they need to go through proper training programs. So they need to understand the journey this health extension program has gone over the last 15 years. So we wanted to train our local people as well at this institute so that they understand the philosophy, the principles, and the governance, and how effectively this program should be managed, and so on, and the growing concepts that we have been bringing into this program, like the Health Development Army, the social accountability, the scorecard systems. There are a lot of things that we have included into the health extension program to facilitate the dialogue and engagement and empowerment of the community in terms of taking control over the health system in general and the health of individual families and so on. So this institute will also be tasked in terms of providing training to our local managers in Ethiopia. And above all, this institute fits into the new vision we have in Ethiopia, which we call it Health Vision 2035, where we really want to achieve the targets that have been set in the Sustainable Development Goals and even do better. So we are talking about ending preventable and maternal and child health diseases, ending communicable diseases, all these kind of ambitious targets that we have set. And these ambitious targets have to be achieved through a robust and strong primary health care system. Ethiopia will, if the vision we have for the country is achieved, we will join the middle income countries status by 2025. So still, the economy of the country will not shoulder a tertiary treatment kind of focused health system. So our focus has to be primary care. But the problem with a growing economy, with a growing middle income and middle class communities is you will have these vocal groups who will advocate for the most expensive health services to be available in the country. And politicians, parliamentarians could easily be swayed towards investing in these big infrastructures in big cities that may not address the health needs of the majority of the people. So this primary health care institute will help us to make sure that our health system continue to be anchored through primary health care, because this is what we can afford, and this is what is cost effective. And it has shown time and again over the last 15 years in terms of helping the country move forward. I was discussing with Bob and Oying earlier that last week the macro team, the DHS team with our Central Statistics Agency were presenting a preliminary result, a very first preliminary result of our DHS 2016. And the results are good. The trend has continued. And, you know, we did this DHS between January and June of this year. The data collection was done between January and June. And it was the worst of times to do this DHS because we had the worst drought in our history, recorded history, this year and last year. 3 consecutive rainy seasons have failed in many parts of the country. And many people, in fact, my close friends have advised me to postpone the DHS data collection date, but I said, no, let's do it, and let's see whether we have a resilient system that is responding to you know, such kind of crisis and shocks in the country. And considering the timing of this survey, all the impact indicators, even the outcome indicators are incredible. You will have a chance to look at it in a month or two when the results are out. But this shows that even in the face of serious shocks, you will have a system that can respond to shocks, at the same time ensure that there is continuity of services. And this is what primary care brings into the system, and this is what we want to share to Africa and to the rest of the world. And we wanted Johns Hopkins University to be with us to make sure that, you know, we have the scientific and academic rigor into the courses we deliver to these you know, interested countries and delegations that will come into Ethiopia. One last thing is, you know, while we have discussed about this primary health care institute, we had the opportunity to host a delegation from Namibia 3 years ago. The minister, the former minister of Health of Namibia came. He saw the program, very excited. Then he asked for 2 people to be embedded into the ministry. So we seconded 2 experts from the Ministry of Health to work with their Namibian counterparts in designing the program. And a year later, they have successfully rolled out the health extension program in northern Namibia initially, now all over Namibia. They have, I believe, around 1,200 health extension workers. And the new minister who has assumed office a year ago is extremely happy about the program, and he wanted to continue the production of health extension workers for Namibia because he has already seen a very good coverage in terms of services. So we have seen it succeed in Ethiopia. We have seen it succeed in Namibia, of course, you know, contextualized to their own situation and so on. We have good discussions with South Sudan, with Uganda, and with other countries in Africa who are ready to take this program and roll it out in their countries based on their context. I'm sure Professor Mengesha and Henry will share the plan we have over the next year or so. But this is the vision we have, to have a strong primary health care in Ethiopia that can continuously provide support, training, and leadership improvement to our health workers and managers at the different levels of our health system, but at the same time share our experience to other countries who wanted to start this exciting journey of bringing health services to the doorsteps of people in remote areas. Thank you very much.
Thank you very much, Minister Cassetti. It's a great pleasure for me to share with you a video that Dean Clegg made to celebrate this special moment. So, see if I can get this going here.
Congratulations on the establishment of the International Institute for Primary Health Care in Ethiopia. The world has watched with admiration as Ethiopia has made great strides in improving the health of its population. And as you know, it's done so by using health extension workers who have become an army to improve health throughout the country. We applaud the establishment of the Institute and agree that now is the time to disseminate this model to other low and middle income countries who can benefit greatly from the advances made in Ethiopia. It is part of the mission of my school, the Johns Hopkins Bloomberg School of Public Health, to improve the capacity of institutions around the world to attack the problems that face their populations, the health problems, and to improve their health. We look forward to partnering with you in the establishment of this center to quantitate the impact of this great innovation and also to continue to generate evidence so we can improve the quality, and then lastly, to help disseminate it to low and middle income countries through training. Ethiopia is a great country, and we know it has an even brighter future ahead. We're happy to be a small part of that future.
So now it's my great pleasure to introduce Professor Mengesha Admasu, who is the new executive director of the International Institute for Primary Health Care. Professor Mengesha has been working at the University of Gondar for the last 38 years and has risen up through the ranks, teaching thousands of students, including Minister Cassetti, and has served more recently for the last 8 years as the president of Gondar University. And he has now made a career switch to take over the leadership of this very important institute. And so it's a great pleasure to introduce Professor Mengesha, who will share a little bit more about what the institute is planning to do in the near future.
Thank you, Henry, for kind presentation. Introduce. Good afternoon. I'm very honored and privileged to be here and introducing the International Institute for Primary Health Care. As it has been said earlier, the International Institute for Primary Health Care, it has been established since February 2016. It's almost young. And with the presence of, during the inauguration, with the presence of His Excellency Dr. Kesete Admasu, that was established in Addis. Established with the vision of contributing global revitalization of global movement, health for all through primary health care. The Institute is planning to entertain some of the activities. These are providing short training and capacity strengthening of trainings, identifying need-based for national and international trainees. And at the same time, it's also planning to provide short course training and supporting the managers at all levels, health managers in the country, and also at national. And another task is also given to conduct researches on primary health care, and also organizing fora, national and international conference once or twice in a year. We are also planning to organize, develop a journal after a year time, because we are going to have research officers apart to the trainings. The institution is actually also planned to give this training for national and international. The national and international, they will be together from abroad, from African countries and beyond. In fact, for a lively discussion of the class training, we need to have not more than 25 trainees, 15 from abroad and 10 from Ethiopia. So they can be discussing together. And then the first cohort of trainees we plan to do is the policy makers. You know, the commitment, the secret of the success of primary health care in Ethiopia is that's the commitment of the government toward this community-based research, community-based program, paying a monthly salary for 38,000 health extension workers. It's a great commitment. And these all are females. These all are nominated in their respective countries, localities where they're born and grown up, and knows the culture, identify sensitive cultures in that community. And we believe in Ethiopian context, females are really caring. And so regarding to our maternal and child health problems, definitely it is good to have a smooth relation when a female is interviewing the mother's caregivers at house. And that's why the secret behind that we all have these 38,000 health extension workers are females. Once our neighboring countries, Africans, have learned that we are benefited in reducing child mortality and maternal mortality using our health extension workers. So they used to come and benchmark and take a lesson of best practice of Ethiopia. But it was not in an organized manner. And that's why, as it has been stated by His Excellency Dr. Kesete Birhan Admasu, this institution is established for its purpose that really purposeful and relevant professionals would come to the training center and get trained. So we start with the policy makers who are really members of parliament and also lawyers and economic advisors. For 3 days will be staying in Addis. You cannot keep them more than 3 days because of their commitment, of which 2 days will be class, reflection, debriefing, and introduction, and 1 day is seeing is believing. They will go to the rural setting and see what's going on in the village. What's really expected during this time? A must-take-home assignment for them is a must-have changed attitude than skill, than the knowledge. So that will lead them to have a political commitment back home. The second cohort of group is health programmers. These are, it could be also state ministers, provincial heads, regional heads, bureau heads, and districts level. They will come and will get trained for 2 weeks. 2 days visits, field visits. The other would be case development and class presentation and discussion. The third group would be for 6 weeks, primary health care implementers will be staying for 3 weeks. 1 week would be outside in the field. And the fourth one definitely will be serving us for supporting the capacity of the health officer who have been working at health center level, whether they are in line with the government health sector transformation plan, and at the same time strengthening their capacity in leadership. In doing this, We are working and get sponsored by Bill Melinda Gates Foundation for 1-year plan. And we are also working with Johns Hopkins University. And also this is led by advisory group. The advisory group is chaired by His Excellency, the Minister. And of the advisory group, the members are, majority are international staff. It was purposeful. They will be invited, and we believe that their contribution will be significant. So having said this, I believe that this training and this institution will meet its vision and mission for 3 reasons. Number one, in early age of my time when I was a student, I heard and read about Johns Hopkins University. It's a rich experience in public health, in primary health care, in community-based program. So we are lucky enough that we are collaborating, technically advised by JHU. The second thing is Ethiopia take an advantage, and because of the government political commitment toward this health for all through primary health care, we really feel the advantage and the benefit. So definitely, that's the second point, the commitment of the Ethiopian government. The third point is we are really very blessed. There is no other things that satisfy people than helping those vulnerable groups who really in need of badly to be improved in their health problem. In most of the countries, we are not able to reach, to knock the door of those who have been found in the remote area for different reasons. The accessibility bias will create us not to go to the extent and knocking the door of each and every communities in the rural setting. Within this system, we have tried to achieve, and this is a very important one and of course, this does not mean that every African country would come and copy and paste. They should actually back home understanding very well the advantage of community-based programs, and then they should associate with their realities back home, because Ethiopian population is 100 million close. But there are African countries with 1 million population. So it cannot be copied, the situation, but we need to agree at its importance and commitment. So I think, briefly, these are the points, and I thank you very much for the opportunity that JHU has created here, and also giving a chance to share with you. Thank you.
Thank you, Professor Mengesha. That was terrific. I'm going to take 5 minutes or so just to give you a brief glimpse of what our role at Johns Hopkins is going to be in providing technical support for this. It is a great honor for me to be the coordinator for the Johns Hopkins support to this institute, and I'll be involved in my own limited way, but I'll be marshaling other resources which are really incredible that exist across the university. But let me say first and foremost that we'll be involved, and have already started this, helping to develop the teaching modules, providing technical support from our Center for Teaching and Learning to make these world-class kind of experiences for our students. Minister Cassetti told me when I met with him in August that one of the attractions to him for engaging with Hopkins was the fact that we have such a established online learning program and the technology for teaching that's highly recognized all around the world, and so much experience with this. So we're engaged with the Center for Teaching and Learning. We'll be involved in developing some of the modules that relate to primary health care beyond what Ethiopia is doing specifically, but a broader focus on primary health care and its history and successes in other countries and so forth. We're excited about developing some online platforms so that before trainees come to Ethiopia, they'll have exposure to some material. After they go home, they'll continue to get exposure, and we're looking forward to developing learning communities so people can share their experiences after they go home. The training is the first wave of work of the Institute, but we all know that the research in the longer term is going to be very important. And the research is geared towards helping Ethiopia to keep its own primary health care program at the forefront. It's not perfect, but it certainly is so much better than what exists in so many different countries around the world. And so we envision this research will be working to help Ethiopia continue to improve its program to be the very best that it can be. We're excited about helping the Institute develop a resource center for primary health care that will be an electronic resource center primarily, but have other hard materials as well, but can be not only for the trainees, but for anybody in the world who's interested in primary health care, so they can have the best and most recent available information about it. And then, of course, with the enormous footprint that Hopkins has around the world, we're looking forward to tapping into that and disseminating through our own network the excitement about this new institute and what it can provide. So in short, we're really committed to helping the International Institute for Primary Health Care to make this a world-class institution that people will want to come to, and the reputation is going to be the long-term sustainability of this institution for the long term. We've had Professor Mengesha and I have been meeting with people around the university in the last day or so. We were meeting with Henry Mosley and David Sack, and their long 30-year experience with the International Center for Diarrheal Disease Research, which for me is a model for what this could end up being in the longer term. We were at JPIGO, we were at the CCP, the Center for Communication Programs, and these are the kinds of richness that this university offers that will bring a special added value to this International Institute. So it's a great privilege and honor for me personally, but for the university, and I know I speak for Dean Clegg in this, to be a part of this very exciting new initiative. I've had the chance to meet with quite a few leaders and high-level staff of institutions and donors, and people say that this is the right thing at the right time, in the right place. We've been through decades of highly vertically oriented programs, and there's a great need to work more comprehensively in a more integrated fashion, and it's time to bring back primary health care at the center of so much of our work. And so we think that this is going to really catch on. There's a lot of buzz about this, as Minister Cassetti knows better than I do. And so I think there's going to be a lot of excitement moving forward. It hasn't been an easy startup. We've faced challenges, but we know that we'll be, with the help of Minister Cassetti, among other things, we know that we're going to be able to move forward in this. But one of the things that really excites me about this is that Bill and Melinda Gates have discovered primary health care, believe it or not. And so they realize it's important, and they're putting a lot of time themselves into learning more about it and thinking about what the Gates Foundation can do. Their staff are involved in this. They haven't come forth with anything serious yet, but we know they have the potential for doing so much more in this important area. So I hope this will be one of the beginning points in which we can all look to for a new era in which primary health care is moving back into the center for global health. So with those words, let me ask His Excellency Minister Cassetti to come up to the stage with also Professor Mengesha, and I want to have a chance for you all to ask them a few questions, and if you have any comments, we'll be happy to receive those too. So let's see. We have your name today. Yeah, okay, good. So we have a few minutes for questions and discussions. So we have microphones out here, so feel free to cast your questions to either one of our distinguished guests.
obviously been very exemplary both in its commitment to primary health care and in the accomplishments that have been shown from implementing it so widely in the country. And I do applaud the commitment you've made to continuing with the unfinished agenda, reducing the deaths of women, the deaths of children, and I'm sure you'll be able to do that. But as you said, Mr. Kesete, you're going to be under pressure to do many more things. Universal health coverage is really much broader, and I guess I really would like to hear your vision about how primary health care might evolve through the community-based platforms you have with the Health Extension Program in the next 15, 20 years, and the target time point that we're talking about for the SDGs, whether it's the non-communicable disease agenda or a mental health agenda or the many other aspects, and of course, financial protection as part of the universal health coverage. So how do you make the progress in very effective ways that you have made for the other agenda, the agenda of women and children and mortality, to go more broadly in the future?
As you know, Bob, what makes the Ethiopian Health Extension Program unique is it addresses major public health problems in the country. So although we talk about maternal and child health as important public health problems as they are, the health extension program is beyond MCH. It includes the disease prevention, which includes HIV, TB, malaria, now NTDs. We have hygiene and sanitation. The health extension program has 16 packages, and these 16 packages, we believe, reflects on the highest burden of disease and public health problems in Ethiopia. And as we succeed in addressing these communicable diseases and these problems related to hygiene and sanitation, obviously other problems will definitely rise. NCDs, injury, already NCDs are on the rise, and because of the improvement in road infrastructure throughout the country, injuries has also become a major problem. But we believe that this platform, the health extension platform, could continue to embrace new dimensions, new requirements into it. So when we talk about the platform, it has a capability to address a range of issues, but it has to be properly defined. It has to reflect the true situation in the country. When we started the health extension program, many people were hesitant, particularly donors, because we came with 16 packages of services to be delivered through these health extension workers. What the world has been used to was a vertically tailored community health workers program. So it was in a way disruptive because we brought a comprehensive health program. But once the program demonstrated to be successful, there were a lot of pressure. Still, there are a lot of pressure to add more into this health extension platform, which, in a way, unless it is properly managed, will make the program ineffective. So we always make sure that whatever additional package we include, it has to reflect the burden of disease in the country, but at the same time, our health extension workers have to be properly trained. So we designed a career ladder for our health extension workers. So I'm glad to report to you that 10,000 of our health extension workers out of 38,000 have now received, according to the Ethiopian educational standards, what we call a level 4 training program, which makes them nurse equivalent. And their salary is better, their education is better because they receive a 1-year training program to improve their skills. And as part of this level 4 health extension program, we have included NCDs. We identified 4 diseases, diabetes, cardiovascular problems, oncological issues, and mental health and asthma are part of this NCD package that is included into the Level 4 Health Extension program. So over time, when we train all our health extension workers, the platform will be able to deliver preventive, promotive, and basic curative services in relation to NCDs as well.
Great.
Hello. Thank you so much for this talk. It was really inspirational for budding professionals like us, public health professionals like us, who want to work at the grassroots level and at the community level. My question is that when you're training these health extension workers, what are the indicators? How do you choose them? How do you make sure there is no attrition later? Because they form the base of their program. So what are the indicators? You mentioned that they are women, but what other than that? Like, how do you choose them?
Yeah, when the program was started, we set a criteria. As Professor Mengesha said earlier, we make a political decision to make all the health extension workers females. So 99.9% of the health extension workers are females. There are some males, into the program, but mainly amongst nomadic pastoralist communities, because we couldn't get women who fulfill the criteria. The second one is they have to be high school graduates. So that's also important. The third criteria is they have to be from the same village where they will be assigned to work. So in cases where there are more qualified candidates who fulfill this criteria, the community has to decide which ones should join the program. So basically they hold a community conference and say, okay, the government is going to train health extension workers for us. We have 6 or 7 who fulfill the criteria. How many of them should go? Which ones should go? We usually give 2 per village. Because, when I said earlier in my talk, we made mistakes when we started the program early on, because when you create this program for rural communities where health extension workers will be on a government payroll, the issue of nepotism, recruiting the wrong kind of people, people in the cities who will never go back and work in the rural areas in those villages, but will continue to receive their monthly salaries. That kind of mistakes have been made in certain parts of the country. That's why in the second year of recruitment, we said, okay, the community has to decide. They have to vet the whole process. And even in recruiting, those people who needs to go. So these are the criteria, and they receive a 1-year training program, standard training program, which makes the Ethiopian program unique. Because in other places, community health workers receive only 2 weeks, 3 weeks, or 6 weeks kind of training program. But this is a 1-year training program, and they are part of the formal health system. So they have a clear career ladder. So every time when they perform very well based on the performance measures, they will be eligible to go to the next level. So the 10,000 health extension workers I mentioned earlier, they are the best performers amongst the 38,000 health extension workers who had the opportunity to advance their career in the health extension program and go to the next level.
Does it ever happen that...
Can you speak in the microphone, please? It's being recorded.
Does it happen that the village woman is married and she goes off to a next village? Then what happens? I'm sorry.
Yes, no, that's a good question. The reason I laughed was, my predecessor, who started this program. I was working with him, Minister Tedros, who is now our Minister of Foreign Affairs, and running to be the next WHO Director General. Whenever he and I go to the field to see the health extension program and interact with the communities, agriculture, we have agriculture extension workers who are predominantly males. So whenever we go there, the agriculture extension workers used to refer to Tedros as their father-in-law, because when health extension workers are all females, and when you have agriculture extension workers who are males, and both are paid civil servants, relatively better off than the average, the opportunity to know each other, and so most of them, they got married but stay in the same village because they got married to agriculture extension workers or primary school teachers and so on. But there are some who had to leave the post. So the attrition rate of the health extension program, 10 years after we started the program, is still low, 7% annual attrition rate. So we have to train on annual basis to replace those who will leave the post, but the attrition rate has been very, very low and within the acceptable margin.
That's amazing. Thank you so much.
I think we have time for one more question or comment. So please. Oh. Sure, okay.
I'd like to thank both the speakers today. You each mentioned research, one in the context of the Institute and the other in the terms of in evaluating the Community Health Extension Worker Program. And that evaluation was being done with DHS data, which is only collected once every 5 years on average. Considering how important this program is to Ethiopia's social development, what data systems are being put in place so that you have more information about what's going on at the rural level in communities? And how are you going to be able to use that information system to improve the Community Health Extension Worker Program? Thank you.
Yeah. One of the best mechanism to track how well this health extension program is doing is to get real-time data from the health extension workers, from the families, and so on. So one thing we have done is we rolled out what we call a family folder, where every health event is recorded on the folder. So we have 18 million family folders now rolled out throughout the country. So it's easy now to verify and validate the service data using the family folder, which has been difficult in the past because you get only the tallies and the numbers at the health post and so on. By rolling out the family folders, you can actually go one step down and verify it at the household level. So the paper-based family folder has been rolled out. Now the big thing in our health sector transformation plan, we have 4 transformation agendas. One of the transformation agenda is information revolution. And through that information revolution, we want to address 2 revolutions. The first one is the mindset revolution of the health workers. People who collect the data have to value the data. Otherwise, you will not get good data. So, the system has been designed in a way where reporting to the higher authorities is the main driver of data. In those kind of contexts, it's always difficult to have good quality data. So we will work with our health workers across our health system to, make sure that they understand and value data, but use it to improve decisions at individual patient level as well as at a programmatic and planning level. So that's one aspect of information revolution. The second aspect is obviously digitization, the use of technology. So we will start with digitizing the family folder. We have received substantial support from our donors. So I believe that over the next year or so, we will digitize 18 million family folders, and we will have the opportunity to get real-time data from every village. That's one. The second, we have a number of surveys that are going on. We have a mechanism with the World Bank, a soft loan, an IDA loan, which is performance-based. It is called P4R, Program for Results. So we agree on the achievement of indicators, certain indicators, and the achievement of those indicators triggers the disbursement of funds. And some of it is through routine information, some of it through health facility-based surveys, some of it through a community-based survey. So every 2 years or so, we have a nationally representative as well as regionally representative information that is coming out of it. And of course, we have the DHS. And on top of that, we have the DSS, the demographic sentinel surveillance sites. Because the country has expanded its network of universities throughout the country, we have now around 10 DSS sites that generate data, and we are trying to triangulate the DSS findings with the routine information, with the DHS and so on, and have a feel of where the program is heading.
Okay, thank you very much, Minister Cassetti. We're running out of time, as I mentioned in the beginning, and we have to leave the room shortly after 1:15. So I want to invite now Professor David Peters to come up with Mr. Oying Rimon, the director of the Bill and Melinda Gates Foundation, and David, as I mentioned, is the chair of our department, to make a few comments. And we hope that Josh Sharfstein will be shortly. He was tied up and will be coming along, but he may not make it, but if he doesn't, we've got plenty of good opportunity here for some thoughts from some two distinguished people. So David, why don't you make a few comments?
Thanks. And first of all, let me also add my congratulations, Honorable Minister, to you and the Ministry of Health, both for past achievements that have been tremendous in the area of primary health care in terms of implementing and getting results, as well as the vision for the future, and that includes the establishment of the International Institute for Primary Health Care. It's a real landmark, and I'm delighted that you're going this direction, recognizing the need to not just to build on past accomplishments, that you need to continue training, to share it elsewhere, to build the research and link it to how you are delivering services that need to evolve, and that's terrific to be part of that. I think it's also quite exciting that the Gates Foundation is part of this. They have done so much in the area of technologies and service delivery. To be joining in this effort to building institutions and systems is very exciting. So I think that's a tremendous part of this initiative. And lastly, I think it's a tremendous privilege for the school and the Department of International Health in particular to be a partner with you on this. The original mission of the department was to collaboratively build capacity to solve health problems at local level, at national level, and international level. And this is exactly the type of thing that the department has been and loves to be a part of. Primary health care, as Henry reminds me, is part of our DNA in our department. We started working with that orientation. We're very much part of the work for Health for All and by the year 2000 and the Alma-Ata declaration in the late 70s. We used to talk about combining the disease approach, the health services approach, and the community approach, and this is another opportunity, a way of bringing those together as we look at not only the service delivery side of things and bringing in new technologies, new approaches, but also to bring in the research that will help us evolve, and particularly the notion of the community accountability approaches that you mentioned. So again, delighted to be part of the Institute for International Programs and the broader vision for Ethiopia's development in health and social development. So thanks.
Thank you, David. Oying Rimon was in the room when Minister Cassetti met with Dean Clegg and President Daniels and asked these two leaders of our university if they would help him establish this institute. And Oying has been working with me as my advisor and guide in this process, and so it's great for you to have the final word, Oying.
Thank you, Henry. But before we do that, I would just like to congratulate my friend Minister Kesete for having been chosen as one of the 120 under 40 new generation of family planning leaders. 40 were chosen this year, another 40 will be chosen next year and the year after that. Altogether 120 by the year 2020. So congratulations for that. I found out that Minister Kesete, the first time I met him, was only 36 years old. You know, this was during the family planning conference, and I thought he was the youngest Minister of Health in the world at the time. And by the way, he will also be honored in New York City on Friday in the presence of many dignitaries for this same award. So let me just reminisce just a little bit. It will not be long. So there was a meeting of ministers at the Hilton Hotel prior to the International Family Planning Conference in Addis. And after that meeting, I had a 45-minute, 1-hour standing up session with Minister Kesete in the lobby, if you remember that. And when we were finished, the hotel manager, when you were going out, approached me and he said, "You must be a very important person." So I was like, what do you mean? He said, you held our Minister of Health for almost 1 hour in the lobby. Of course, what the manager did not know, among the things that we were discussing, was the dream of Minister Kesete, ultimately his legacy, to set up an international institute for primary health care, which we are now here today. So I said, let me try to arrange a meeting with our president tomorrow, President Daniels and Dean Clegg, and maybe you can articulate this dream and this legacy you want to leave behind, you know, for your own country and your own people. And that happened, and the President, Ron Daniels, and Mike Klag committed to assisting the Minister of Health in whatever way we could assist Johns Hopkins can do to help make this reality a dream. So fast forward, the Dean assigned Henry, our foremost expert on primary health care, to be the lead person on this. And we visited Ethiopia to do the landscaping for this. And with us in our field visit, in our visit to all the other important players there, was Dr. Tedla. Dr. Tedla, thank you for being here today. We went to the Gates Foundation, made our elevator pitch. We went to USAID, we went to WHO, we went to UNFPA, we went to UNICEF, and we were not able to see World Bank. But every single one of those institutions were prepared to assist in whatever they could at the local level and internationally by making sure that once this is set up, the elements of AID, UNICEF, UNFPA, WHO outside of the country should be able to support the delegations that would come to the Institute to get trained. So let me just end by saying that it is indeed a privilege to be part of this dream of yours, to not only for your own people, but to help the rest of the world learn from the experience of Ethiopia, and being humble in admitting that there's still more to be done and more to be adjusted to make it the best program there can be. So thank you very much for the privilege of inviting Hopkins to work with you on this very important project.
So our time is up. Unfortunately, we need to be out of here in 3 minutes, but thank you all for coming, and I hope you get a sense of the importance of what we're engaged in, and it's great to have you a part of this. And a special thanks to Minister Cassetti, who got off a plane at 8 o'clock this morning and came straight here, so we owe him a debt of gratitude too.